Lovely, thank you, Ralph. So hi everyone, I'm Shrina. I'm one of the paediatric trainees working in Swansea at the moment, and I just want to introduce our lovely team. So myself and our team, who are from Cardiff mostly. So we've got Dr Christopher Dadnam, who's on the call with us today, and Dr Rebecca Hewitson. Those are both of our PEM grid trainees. And we've also got on the call today Dr Jeff Morgan, who's a PEM consultant working in Cardiff. This paper that we're about to sort of go through in a case-by-case format is also one of the other consultants working on it is Dr Indu Thakur. Unfortunately, she can't make it today, but she is our wealth of knowledge for everything paediatric hematology and oncology related. So today we want to look at how we could recognise sickle cell crises in a paediatric emergency department setting. This is a paper that we published last year, and it's written, I'll give you the link to it later on in the slide presentation, and it went through basically some cases looking at how to recognise crises, how to manage them. So what we're going to do today is basically look at what is the purpose of this session, why we've all come together, review some very basic pathophysiology in relation to sickle cell, and then look at scenarios. So we're going to look at acute pain crisis, chest syndrome, stroke, abdominal pain, infection and trauma, and we're going to split these cases up. And then at the very end, we're going to look at just a brief overview of how to manage acute sickle cell complications. The format of this is going to be that after every case, we'll take a couple of questions. So we'll break between each case just for about 4 to 5 minutes. And if you have any questions with regards to that particular case that we just go through, pop them into the chat box. I'll have a look, and then me and my colleagues can come together to answer any of these questions. So the first thing is to just look at why we're here today. So the purpose of this session is to just look at the acute complications. Sickle cell is the most common inherited disorder in the UK. And between 2001 and 2010, we've seen hospital admissions increase by over 50%. There are estimated 15,000 people in the UK who live with sickle cell disease, with approximately 270 new ones being born every year. So sickle cell disease is more prevalent in people of African, Afro-Caribbean origin, Mediterranean, Indian, Middle East. But given that there's global increase in migration, travel, and we've improved the way that we manage sickle cell as a whole, recent figures show that by 2050 there'll be an increase of maybe 30% in the number of children who will be born with sickle cell in the UK alone. So looking at all these figures and putting this together, it's essential that we recognise sickle cell complications early on, and there is a comprehensive management pathway to reduce mortality and morbidity throughout. Now, just a really brief slide looking at pathophysiology. So sickle cell disease, it's an autosomal recessive disorder where there's a mutation, a base pair point mutation, which substitutes glutamic acid here into valine, and then this produces hemoglobin S, known as sickle hemoglobin. When your body is under stress, such as infection, trauma, the red cells will alter their structure and they'll lose their ability to function at full capacity. The red cells therefore will stick to each other, they'll cause microvascular occlusion, and they'll have complications associated with sickle cell that we're going to go through today. If you're interested in the pathophysiology at more of a further extent, there's a video, I think, on YouTube that the network has put on from a previous meeting, which you can go and have a look at. So, case number 1. The first case, we've got a 5-year-old Indian boy who presents with severe pain in his left leg. There's no history of trauma, viral illness, fever or swelling. There's no redness, no bony tenderness when you palpate, but he's in a lot of pain despite regular paracetamol and ibuprofen, which has been given at home. You see him in triage and the pain score is 8 out of 10. And the parents say that he was out playing in the snow a little earlier today and they think this might have triggered his pain. So the questions that I want to pose to you, and the questions I want you to just spend a couple of seconds thinking about, is what part of this presentation stands out to you? What are your differentials here? how would you want to initially manage this sort of scenario if it came to your emergency department? And what type of analgesia do you want to use? How do you want to monitor them? And is there anything else you can think of that you would want to do with this child here? So bear these sort of questions in mind going forward, and these are the key points that we want to discuss. So what parts of the presentation stand out to you? For me here, if I saw this in an emergency scenario, I'd think, well, the severe pain with no history of trauma or fever or any swelling, that stands out to me. The child is in a lot of pain, even though they've had some regular paracetamol and brufen given to them. And this little key fact there about playing in the snow may have triggered this. So these are the key 3 things that stand out to me. So in this scenario, we're looking at an acute pain crisis, secondary to a vaso-occlusive crisis. I want to just draw your attention to this infographic here. This is from the International Sickle Cell World Assessment Survey. It was published in 2019. And this survey is a multi-country survey. It was ran across 11 countries, so that included North, South America, included Europe, and it included Africa. And they looked at a good number of patients. They looked at about 1,500 patients. So here, the first thing I want to draw your attention to is that the patients who completed this survey, they reported a higher number of VOCs compared to current published data. So what this actually suggests is that the number of vaso-occlusive crises are being underreported in current literature. 90% of the patients taking this survey experience at least one VOC in a year, and often they don't seek medical attention. So I just want to highlight this proportion of this infographic here down below. 39% of patients said that the main reason they choose to manage their pain at home is because they've had a previously poor experience at their ER or their hospital emergency department. And 26% say that they didn't seek any help because of a perception that the healthcare providers don't fully understand sickle cell disease and their pain. And 19% said because their pain was so severe they couldn't actually leave their house. So this really highlights the need for a comprehensive and standardised pathway to optimise acute pain crisis management when a patient with sickle cell walks through the door. Now, from an ED perspective, when you look at this case, there are multiple differential diagnoses for a limping child or a child with pain in their leg that you should keep at the back of your mind. I'm not going to go through the whole list, but the one that's not on here is NAI, so non-axial injury is something that should be kept at the back of your mind as well, along with the rest of these. So looking at the differential diagnoses for limb pain, patients with sickle cell, they are predisposed to acute orthopaedic complications. So consider things such as avascular necrosis, osteomyelitis, and septic arthritis when you see these children presenting with limb pain. Avascular necrosis, it commonly affects your femoral humeral head. The weight-bearing part of the bone, it collapses and you get this crescent head sign. So I just want to focus your attention to this image here. The 2 yellow lines there, you can see there's a faint translucent area. I don't know how well it's projecting on your screens, but the 2 arcs there highlight the crescent sign there. Osteomyelitis, so the most common organism is Salmonella or Staphylococcus aureus. That can cause osteomyelitis for these children, and they may require therefore prolonged antibiotics or even surgical intervention. And then with your septic arthritis, as you would with any septic arthritis, bloods including full blood count, bone profile and a CRP are paramount. Refer to your orthopaedic colleagues as soon as you think this could be a potential diagnosis. And then you may require an MRI, which is a gold standard imaging for persistent pain in a large joint. And as I said previously, these are just 3, the other differentials that we saw in the previous slide. Keep those in the back of your mind as well. And don't forget NAI. I want to just quickly draw your attention here to this slide. So with vaso-occlusive crisis being the most common presentation, assessing and managing pain is essential. There are these two scales are very handy when you're not used to working with such small children, or you know, they come through your ED department, you can signpost them to these. So FLAC pain score, this is great for neonates and infants up to 2 years of age, and you can assess their pain using the score and score them and then see where they lie. And then for children aged between 2 to 8 years old, the Wong-Baker scale is really good, and this can tell you what their pain is doing and where they are when you see them at triage. For children between 8 and 16 years, you can give them a visual pain ladder or just ask them to give you a score out of 10, and they should be able to tell you. And there's a lovely article on this on DFTB, which is Don't Forget the Bubbles. It's a lovely site for paediatric, anything paediatric. So managing this patient, so this 5-year-old boy with this pain, how do you manage it? Well, the current NICE guidance says that the patient or the carer or the parent should be regarded as the expert when you manage their pain. They've been dealing with this at home. This is something that happens quite often. So ask them what's been used, ask them what they've done at home on previous occasions, use age-appropriate pain scoring, as we just saw. With these kids, hypoxia, dehydration, infection, their cold exposure like we have here, they're common triggers. So offer strong analgesia, offer paracetamol, offer your NSAIDs, your Brufen, offer a stronger opioid. Intravenous access can be really challenging for patients with sickle cell, so an intranasal method is really good and it's really effective. Ask parents when they will last given analgesia, so make a note of this at your triage and at your clerking to avoid any sort of drug errors, and get analgesia delivered within 30 minutes. The RCPCH standards of care, they say actually that analgesia should be delivered within 20 minutes, and you should review it on an hourly basis until you get good control of their pain. And then how do you want to monitor them? Well, pain should be reassessed, like I said, every 30 minutes to every hour until you have any sort of any good adequate relief is achieved. And then sedation scoring for these kids is really important. If they're naive to opioids and if you're giving them a lot of opioids, you need to make sure that you keep an eye out for their sedation scoring. In terms of any other measures, you need to make sure that they're adequately hydrated and you keep an eye on their fluid balance. Consider laxatives for longer term management. So I know this might not be the first thing you think about, but if they are requiring regular opioid treatment, then you should consider laxatives. And incentive spirometry. So this is I don't know if many of you have come across this, but it's a handheld medical device to sort of help improve the function of their lungs. And if they come with any sort of painful crisis, spirometry will prevent progression to acute chest syndrome, which is something we'll come on to later. So this was case 1. I'm just going to pop open this team screen to see if we've got any other questions in our chat box. If you have any questions at all, please just pop them on the side and me and my colleagues can help answer them. Okay, I don't think we've got anything coming through at the moment.
Shrina, it's Jeff here, Jeff, the PSA&E consultant from Cardiff. Hello, everyone. I was just going to mention really that paediatric A&E, we see limping children. It's a very, very common, frequent presentation for us in paediatric A&E, and certainly in Cardiff, we probably see at least 1 or 2 patients a day. Our population of patients with sickle cell disease in Cardiff isn't as high as many other regions across the UK, but it's something we are very wary of. We, again, in Cardiff, we're very lucky. We have a haematology paediatric team unit on site, so we liaise very closely with our paediatric team, so with our haematology team. So in our circumstances, if a patient does present, a patient with known sickle cell disease does present to the emergency department, we certainly have early communication with the haematology team to support us in managing these patients. It might be different in everybody else's hospital environments and accessibility to haematology specialist advice.
Thank you, Jeff. Right, so I don't think there's any questions for this particular case. So yeah, like Jeff said, limping child, it's a very common thing. Just the main things are get good control of their pain and offer good analgesia in a timely manner and reassess often. Now, case 2. So give you a couple of minutes on this slide just to have a little read. So here we've got a 6-year-old who's presenting with acute shortness of breath. She's got a background of asthma, which is managed with inhalers. When you examine the child, you notice that there's increased work of breathing and they're complaining of chest pain despite some oral analgesia. She's got a cough and a low-grade temperature, so you isolate her for COVID-19 and you get her swabbed. The chest x-ray that you've done, you can see some perihilar changes there, and you're exploring the family history when mum says that she's got sickle cell disease, but she's not very sure about dad. So you know that the child was born in Nigeria, but they didn't have any newborn screening when they came to the UK. So again, let's look at this presentation and think to ourselves, what stands out? What are the main differentials you're thinking of here? What sort of things do you think you should look for on a chest x-ray? And of course, how would you manage this? So with regards to the presentation, it's acute shortness of breath and she's got a background of asthma. So we've got a couple of differentials here. They've also swabbed for COVID-19, so that's another differential there. There's a cough and there's a low-grade temperature. There is something going on in the chest because you can see some hilar changes there, some perihilar changes, and we know for a fact that this girl suffers from sickle cell disease. So differentials, well, asthma exacerbation should be one of the main things that comes to mind here. As they've already said, COVID-19 or infection. But given that she has sickle cell disease, acute chest syndrome is another one that should be kept high up on your list. So when you're doing a chest x-ray, what sort of things are you looking for with acute chest syndrome? So any sort of new pulmonary infiltrations are key to look out for, and any features of lower respiratory tract infection as well. Acute chest syndrome, it is the second most common complication that leads to death. Therefore, all suspected patients, they have to be hospitalised, and it is a rapidly evolving condition. It's also important to bear in mind, especially in this case, that a pre-existing diagnosis of asthma is associated with increased incidence of ACS, so acute chest syndrome in children that already have sickle cell, and you can have an asthma exacerbation alongside an acute chest syndrome, so they can go hand in hand and present together. How do we want to manage this? Well, you want to manage this with your A, B, C, D, E to start with, depending on how well or unwell the child looks. ACS, it's accompanied by a really steep reduction in their hemoglobin levels, so they need oxygen therapy. Try and keep their oxygen saturations above 95, or if they're well known to you, keep them within 3 of their baseline. Start them on some antibiotics. IV cephalosporin and a macrolide antibiotic are great choices. As we've discussed, analgesia is key, so again, go back to those pain scoring charts and give them their analgesia in an effective way and reassess. And then hydration as well is really important. So just to say, especially in this climate, in the COVID-19 pandemic, the latest evidence indicates that the potential risk of a serious illness to children is low, including those with sickle cell disease. The difficulty does arise when you're managing sickle cell disease children who present with the potential diagnosis of paediatric inflammatory multisystem syndrome. So that's the PIMS, TS. So it's important for you to try and distinguish between PIMS and a sickle cell episode while promptly consulting with your haematology and infectious disease specialists. Ideally, try and get hold of a paediatric haematologist if they're available to ensure that you've got the right diagnosis and management here. So that was scenario number 2. Any questions for that one? Again, pop them in the chat box and we can have a little chat about them now.
So I think whilst we're waiting for them, I'm Chris, I'm one of the PEM trainees. I'm currently working in Leicester, but as a paediatric trainee in Cardiff when this was done. So just regarding acute chest syndrome, so I actually experienced a recent case, but actually the child presented in minors with rib pain, and they thought mechanism of injury was related to the child hitting their side against the soft armchair. So I think in this case, again, so acute chest syndrome can present just with pain, and parents, because it's so insidious, might not recognise it being related to their sickle cell disease, and actually took a lot of prompting to get dad to realise, was it related to his sickle cell, and the child was moved over to majors, had saturations, analgesia, chest x-ray and hydration therapy. But again, these can present not just from a sort of a wheezy child or an increased work of breathing, but also they can present in the minors areas. So just be aware that if things are not matching up and the history doesn't really seem to make sense, then maybe they can also be associated with underlying medical problems such as sickle cell.
Thank you, Chris. We've actually just got a question through from Assad, who said, do you usually do arterial blood gas sampling in children?
So Assad, thank you. It's Rebecca Hewitson here. I'm one of the other PEM trainees that's part of this group that's put the presentation together for you today. So my background is very much A&E, paediatric A&E, but I've worked in some of the big London centres where there's a large number of sickle cell patients as well. No is the short answer on arterial blood gas sampling in children. We tend to use capillary blood gas sampling as a actually very effective proxy for what's happening, and I think certainly from a paediatric background, our comfort zone is in interpreting the capillary blood gas samples, and we're very much used to using those. And some of the paediatric intensive care units I've worked on will sort of consider using the capillary blood gas samples rather than always arterial. Obviously, if they've got a line, you start using arterial, but capillary gives you a pretty decent estimate of what's happening. So we tend to stick with those. It's a very painful procedure for children as well. There's also a really helpful point here in the chat from Musin that's said about the chest syndrome patients deteriorating very quickly. Absolutely, it's terrifying how quickly. And I think Chris's example there of a patient who had been triaged to minors, recognising the seriousness of that and taking them straight to HDU, because they can just crumple before your eyes from a patient that looked quite well when they arrive, and that kind of hypoxic spiral just can really deteriorate fast. So really helpful point there in the chat there about informing intensive care early, particularly for any colleagues dialed in from district general hospitals where you don't have your intensive care on site, having a conversation with your transport team as well to give them a heads up about a very sick patient and your kind of HDU settings in your hospital and what's the limit of care you can provide where you are. Another really helpful point about transfusions as well. We'll talk about that a bit more in the next case as well. There's a lot of practicalities to think about in A&E about what's your rate limiting step and planning in advance for that if you're going to need blood. So I think, should we move on to the next case now from that, Shrina?
Yeah, perfect. Thank you, guys. Thank you for your questions as well, everyone. So case 3. Here we have a 15-year-old boy who's presented with an altered gait and some left-sided weakness with a headache. It started shortly after he finished a cross-country run at school, and the weakness didn't resolve after 2 hours, and now he can't lift his left arm. He has never suffered from these symptoms before and denies any sort of head injury. There's no clinical signs of meningism, and on review of his previous medical records, you can confirm that he does also suffer from sickle cell disease. His most recent transcranial Doppler was 3 weeks ago, and that was reported to be borderline, and there were plans in place to repeat this. So, what parts of this presentation stand out to you? How would you assess the patient and how would you manage them? And again, one more sort of different thing to think about in this scenario is what sort of neuroprotective measures should we think about if we need to put these in place. So in terms of what stands out, well, here the altered gait is a big red flag, and the left-sided weakness with the headache. The fact that this weakness hasn't resolved after 2 hours and now he has a left arm which he cannot lift, and he's lost all power there. We know that he is sickle cell. He's a sickle cell patient, and that his most recent scan was borderline, so there was something going on there. So again, headache is a very common presentation that comes to ED, but with those who suffer from sickle cell, the main thing that you want to keep an eye out for is stroke. So children with sickle cell disease are at a 250-fold increased risk of stroke, 90% of which are acute ischemic events. So without any sort of primary stroke prevention, approximately 10% of patients with sickle cell will suffer with strokes, and 20 to 35% of patients will have silent cerebral infarcts. So they'll have silent TIAs, or they'll have TIAs preceding a big ischemic event. The stenosis can be seen on high blood flow velocity transcranial Dopplers. So when you do these scans, there are specialist radiographers who do these for sickle cell patients. You can see stenosis commonly of the internal carotid artery, the middle cerebral artery, or the anterior cerebral artery. Often with the patients who have borderline scans, they'll go and have another one. If you have 2 borderline scans, you're usually commenced on a transfusion program. Annual transcranial Doppler scans are performed, especially on high-risk patients or those who have consistently abnormal scans, and then they're offered these transfusion programs, or they're offered hydroxycarbamide to try and reduce the risk of stroke. In terms of assessing the patient, you want to explore a thorough history. So this includes a bystander history. Try and make sure you get as much information as you can about things like head injury or trauma. Anyone who presents with a reduced GCS, paralysis or seizure, you go back to your ABCDE approach and manage them from there. In terms of imaging, you want to try and get an urgent CT head plus or minus angiography within an hour of their presentation, depending on where you are and what the services are. And you want to discuss with haematology and neurosurgery as clinically indicated by the presentation, and do that early on. So these are the RCPCH stroke guidelines. So I don't want to go through all of this. I just quickly want to draw your attention to this box here, which I'm going to zoom into. So like it says here, the algorithm is not wholly applicable to, in children with sickle cell disease. So if you have a sickle cell patient and you suspect a stroke, like it says here, discuss with paediatric hematology and discuss regarding exchange transfusion, even if your initial CT is normal. So in terms of neuroprotective measures, so these are things that you want to try and do if your patient has raised intracranial pressure signs. So for example, if they've got a Cushing's response, they're bradycardic, they've got high BP, if they've got late signs such as sunsetting, or they've got papilledema, or even if they have early signs in terms of if they've had an hemorrhagic stroke, they could have things like vomiting, visual disturbance, fluctuating GCS, they might start seizing. You want to think about these neuroprotective measures. So you want to avoid hypoxia, try and keep their saturation, their PaO2 above 13 and their saturations above 98. You want to try avoid any sort of hypotension, so aim for their BP to be above the 95th centile for their age. Keep their CO2 levels down, try and maintain their core temperature between 36 to 37 degrees. When they're in the bed, keep them head tilt up at about a 30-degree angle and keep the head in the midline. Make sure you do a blood sugar and avoid any sort of hypoglycemia to try and keep the blood sugar above 3. And again, as with any other of these cases, make sure they've got adequate analgesia and also sedation in this case as well. So most patients who present, most SE sickle cell patients who present with an acute stroke, be it hemorrhagic or ischemic, the main aim should be to reduce the circulating sickle hemoglobin to less than 30%, and try and restore the hemoglobin concentration to anything between 100 and 110 via exchange transfusion if you do have that service available. if exchange transfusion is likely to be delayed by more than 6 hours, try and give regular top-ups of blood transfusion to provide and elevate that hemoglobin to between 100 and 110. And again, discuss really early on, so each case can present with specific individual circumstances, and when you discuss this with your haematologists, they will guide your acute management to try and make sure we're improving cerebral oxygenation as best as possible. So that was case 3. And again, if you have any questions, please pop them into the chat or any comments at all.
Shrina, it's Becky here again, if I can just chip in. Oh, so yeah, someone asking about any place for thrombolysis. It's a great question, actually, because the reason for kind of highlighting those RCPCH guidelines is that the emphasis of those is very much on thrombolysis. However, for sickle cell patients, the majority of the time that's not the emphasis. The emphasis tends to be more on exchange transfusion and getting the hemoglobin within those parameters that we've just mentioned. And it's really tricky. I think as a default position, when we were discussing this with Indu, who sadly is not able to join our call today, she's our haematologist in Cardiff, our paediatric haematologist, who was part of this team that put together the case series. The kind of normal core things that you're doing for your sickle patients about making sure that they are not becoming hypoxic, and the kind of, from our standpoint from A&E, like in extremis, doing all of your normal raised intracranial pressure management that you would do for any patient. And then really the first step is thinking about getting your specialist haematology advice on the phone as soon as possible, getting your imaging as soon as possible so that you know what you're dealing with, and planning ahead in much the same way as we're talking about the chest syndrome patients can deteriorate very quickly and you need to plan ahead about what you might need. For these patients, if you're going to be doing an exchange transfusion in your hospital because you know that you have facilities to do that, you have an on-site paediatric intensive care unit and specialist haematology, then thinking about making sure you've got wide bore cannulae in, that you've ordered the blood, because the big rate limiting step is getting the blood, and getting access, we all know, can be incredibly tricky for these patients. So I'd say your first step is your standard ABC management. In extremis, thinking about raised intracranial pressure and how you take steps to minimise the impact of that, getting your imaging and your blood and your access lined up. Thrombolysis is not a kind of automatic, yes, this is where we're going for sickle cell patients. The emphasis tends to be more on getting the haemoglobin within the optimal range. But it's very much something you need specialist advice about.
Thank you, Becky. So if there's no more questions on this one, we'll move on to our next case. So case 4, we've got a 2-year-old boy with sickle cell disease who presents with acute abdominal pain. On examination, he's pale, he's tachycardic, and he's clammy despite some simple analgesia. And on initial assessment, you can feel that he's got a mass extending from his left upper quadrant. So same question as before, what bits here do you pick out? What are the red flags here for you? When someone with sickle cell disease comes in with acute abdominal pain, what differentials do you think of? And what clinical features do you look out for? Again, how do we want to manage this patient when they come into an emergency setting? So for me, the fact that this 2-year-old is pale, he's tachycardic and he's clammy, and also paying attention to this mass that's extending from his left upper quadrant are the two sort of key bits that stand out and say that we need to start thinking about managing this patient quite quickly. Abdominal pain differentials, especially with sickle cell patients. So splenic, hepatic sequestration are the two key things. Also looking at things like cholestasis, hepatic or renal vein thrombosis is another thing to look out for. And then you've got mesenteric girdle syndrome as well. So if you think the pain, abdominal pain, is due to vaso-occlusive origin, this is often termed girdle syndrome because of the circumferential distribution of pain. The other differentials, of course, at the back of your mind are things like appendicitis or intussusception. Any patient with sickle cell disease presenting with abdominal pain, they should be assessed for splenic sequestration. This is a complication that is seen mostly in children under 2 years of age. In terms of clinical features, so a rapid hemoglobin drop that causes that abrupt sort of paleness. So when there is splenic sequestration, the sickled red cells, they obstruct venous drainage within the spleen, and this causes further sickling and trapping of the cells, which causes the rapid hemoglobin drop and the clinical picture of a pale child. The weakness, tachycardia with this palpable splenomegaly is another thing to look out for when you're doing your abdominal exam. And then when you get around to doing your bloods, a clinical definition of splenomegaly is anything with more than 2 centimetres with a decrease in hemoglobin of more than 20 grams per litre from their baseline. In terms of management, so if the child is in hypovolemic shock, we need to fluid resuscitate. So they'll need fluid resuscitation and emergency blood transfusion with O negative blood if necessary, if they're not known to you. Or you can give them O positive in males if you need to transfuse them really quickly. So make sure that if you're giving O positive, it's given to male patients and not female patients because of the future risk of rhesus disease in females. So if they're not in hypovolemic shock, you need to discuss with hematology as you've bought yourself some time, and then you can cautiously transfuse them, and ideally with a specific type of blood that is more matched to them. And if alongside of being in shock or not being in shock, they're febrile, take some blood cultures and start broad spectrum IV antibiotics. With these children, aim for a hemoglobin that's no greater than 80 grams per litre to avoid hyperviscosity, especially when you've got sequestration in the picture. When the sequestered cells return to circulation in the subsequent days, you want to avoid the hyperviscosity there. Another key point here is to educate caregivers and parents to regularly palpate for splenomegaly and recognise adverse clinical signs such as paleness and allow for early medical intervention. So giving families the education to be able to feel for the splenomegaly or hepatomegaly early on, it really reduces mortality and complications going forward. Any questions for this one?
Just while waiting, it's Jeff Morgan again. Apologies, I just realised my camera isn't working, so I'll carry on speaking. Again, when we are presented with patients with abdominal pain, it's a very frequent attendance to the A&E department, so it's key to establish whether your patient has a background history of sickle cell disease or not. That would certainly influence your clinical management and decision making. But remember, there will also be patients with sickle cell disease who will also have other causes for abdominal pain, the common causes that we see in children and young people. So your appendicitis, your constipations, which I'm sure we as paediatricians we see day in, day out, and intussusception as well. Your examination assessment, when you're looking at parameters, your heart rate, your blood pressure, your pain score, and your clinical examination, all going to direct you to the potential differential diagnoses. So if we have got a patient with sickle cell disease and we realise we have got the hematological concerns, and we're treating hypovolemic shock, as well as speaking to the hematology, remember we have got our friendly paediatric surgeons, or if you're not in, if you're in a DGH and don't have access to paediatric surgeons, you can see if there's a surgical colleague who's able to come put the hand on the child's tummy to help give you some advice as well, and a surgical opinion. It's always worthwhile working as a team. I'm just looking down through the list of questions there.
Yeah, just some helpful comments here. I think Mamta's pointed out that because we now do neonatal screening in the UK and educate families that mortality from splenic sequestration has reduced, which is fantastic. I guess if you have COVID has somewhat limited international travel, but if you are working in a centre and you have people that have recently arrived in the UK and perhaps don't have an established diagnosis and haven't come from somewhere where there is neonatal screening, it's particularly important to have a low threshold for considering it. And a very good point about parvovirus as well, being associated, slightly preempting where we're going next with our next case. I think with that we should probably move on to the final case, Shrina. No, thank you. It's a very helpful point to kind of make that link between the two, Mamta. Thank you for raising it.
I just note there's a hand up.
Yeah, Mark Layton.
Yeah, hi, thanks. Just a comment about blood transfusion in sequestration syndromes. As the sequestration reverses, the blood that's pooled in the spleen or liver will recirculate. And there have been descriptions of children, adults with sequestration syndromes developing hyperviscosity. So it's very important not to over-transfuse these patients. Transfuse them up to a safe hemoglobin level, and then as the sequestration reverses, the hemoglobin usually increases further, and sometimes does increase excessively. You may need to venesect the patient. And just a practical point about emergency blood transfusions. Most patients will have their extended phenotype recorded, and so wherever possible, even in an emergency, you should try to give them antigen compatible. The blood transfusion laboratory may well have that available in stock to avoid the risk of alloimmunization.
Thank you very much. That's really helpful. Yeah, absolutely. Like you said, some patients, yeah, they will have their blood group already with the blood bank in their local hospital. So as often as you can, try and give them the best matched blood. Absolutely. And yeah, fab. Thank you. So moving on to case 5. This one here, we've got a family from Egypt who present to ED with their 11-month-old daughter. She's lethargic and pale. The father speaks little English, but mentions that the patient has had a cold for the past 2 days and she's a bit red to her cheeks as well. She has a history of sickle cell disease and the parents are concerned regarding the possibility of slap cheek illness. So looking at this again, looking at what parts here may stand out and looking at the common infections that affect sickle cell patients. So when they are infected with particular illnesses, what conditions are they prone to developing? In terms of lab parameters and clinical features, what are we looking out for? And how are we going to manage these patients? So for me, with this 11-month-old, the fact that they've had a cold for the past 2 days and they're red to their cheeks, and we know that they are a sickle cell disease patient, we are worried about slap cheek like their parents are, and we can see here that parents have had some previous education about what sort of things to look out for that they're mentioning it. So what common infections do sickle cell patients suffer from? So parvovirus B19 is a common infection that they suffer from. You get a fever and a facial rash with it. In sickle cell patients, parvovirus, it induces temporary bone marrow suppression, causing an acute aplastic crisis. The chronic hemolysis that sickle cell patients suffer from, it makes these children vulnerable to an aplastic crisis because they have already a lower hemoglobin baseline, and that means that marrow aplasia can result in their hemoglobin levels dropping as low as 30 sometimes. So for these patients who already suffer from chronic hemolysis, this infection, the superadded infection, can cause a very steep decline in their hemoglobin levels. In terms of clinical features and lab parameters, so clinically they can present to you with vague symptoms such as headache, fever, fatigue, shortness of breath, and a rash. lab parameters, so doing a blood film alongside your full blood count is really important. You'll see an absence of nucleated red cells and reduced reticulocytes. You should also, as mentioned previously, perform parvovirus serology and send off for a PCR. So this was just a really quick small case looking at infection and what to do in terms of when you come across parvovirus sort of picture and what sort of things you need to look out for on lab parameters. Any questions for this case? Really quick one.
I guess as well as questions, also any comments, because recognising the expertise as well that we have on the call, and thank you Dr Layton for kind of contributing on that as well, because we are missing our local haematologist or expert paediatric haematologist today, so very grateful for your collective expertise as well, to all learn from each other on this. And on that note, I wondered if anyone had any experience, just to go back as well to the previous case, of thrombolysis for sickle cell patients, if anyone does have anything they wanted to contribute on that as well. There's some more questions come up now in the chat too. So Machine saying about parvovirus, yeah, attacking erythroblasts and switching them off, leading to this aplasia, which is really profound for these children. Yes. And there's a wonderful point here as well from Mamta about pregnant staff members shouldn't be looking after these patients as well, because it poses a risk to pregnant women, and because of risk of high drops via the same kind of profound anemic sort of process. There's another hand come up as well, I think.
Yeah, it's Asad Lukmani.
Yes, hi, thanks very much. I was also going to go back to the stroke case that you mentioned earlier, just about the if there's a lack of availability of automated red cell exchange transfusion. So I think one of the priorities in this situation is not just increasing the hemoglobin, but to lower the hemoglobin S percentage. And I think this is one of the situations where if you didn't have access to automated red cell exchange, or if there was a significant delay, then manual exchange transfusion may be indicated. And obviously that there's a big problem with the training in manual exchange transfusions, because, you know, we're not doing that very often these days. But I think it's still important to bear in mind that that may be indicated in such a situation.
Thank you for that, Asad.
Thank you.
I think on that, we our final case also sort of addresses more about blood and the need for transfusion. Just on this case particularly, it is quite a common, although we've mentioned the redness of the cheeks and, you know, the girl has a past medical history of sickle cell, this could also be just any other viral illness presenting in any child that we see hundreds of every day in ED departments. So I think the main thing is to recognise and make sure you understand from the history taking, is there any past medical history or any issues that they've had before? Because as I said, although we've mentioned they've got red cheeks and we're leading the question onto a slapped cheek syndrome, it's always worth just making sure you tease out those details in your history taking, because as I said, this is a very common complaint into the ED department.
Thank you guys for all your comments. It's really helpful sort of learning along the way as well, and just adding bits and pieces more to this. So we come on now to our last case. So case 6, we've got a 12-year-old boy who sustained an open femoral fracture after falling while rock climbing here in the Brecon Beacons. The family were on a holiday from London, so they're out of area. And the ambulance team on arrival note there's a lot of blood, and the child is in hypovolemic shock. The patient has an identification card stating that he has sickle cell disease. So again, what here is standing out. What blood transfusion specifications do you want to ask for? And what hemoglobin level do you want to try and aim for before you do any sort of surgery or attempt any sort of surgical intervention? So looking just a bit more closely at this, so here we've got an open femoral fracture, so that needs to be addressed. The fact that we are now in hypovolemic shock also needs to be addressed, and the fact that we know this child suffers from sickle cell disease. So putting these things together, how do we proceed with management? So obviously, because of the loss of blood here, we're going to need some blood products. Given that this child is out right now and ambulance crew will be arriving, and they'll put out a call to you stating that this child has sickle cell, what sort of blood specifications do you want to ask for? How do you want to prepare for this situation? So ideally, like we've discussed now, you should try and receive ABO compatible extended rhesus and Cal match blood, and also extended red cell antigen typing should be performed. If the patient is known to the hospital, then request best match blood from your blood bank. And if they're not known to your hospital, as in this case, they're out of area, they're from London and they're in the Brecon Beacons, you'll have to go for O negatives. But you can use O positive, as we've discussed, in males. So with this child, in addition to your standard trauma management, which is your C, A, B, C, D, E, you activate the major hemorrhage protocol in your hospital, and you take these blood specifications and considerations and you try and prepare. What you want to do in terms of hemoglobin level prior to any sort of surgical intervention. So prior to surgery, transfusion can help optimize oxygenation. Try and aim for a HB of around about 100. And with regards to an open fracture, as you would with anyone, cover them with antibiotics early on. I just want to talk about here quickly FES, so fat embolism syndrome, as a complication. It's secondary to widespread bone marrow infarction, and due to its rarity and therefore lack of awareness in non-specialist clinicians, timely diagnosis can be challenging. Once you do recognise or identify that FES could be a potential complication, red cell transfusion has to be commenced really, really quickly. Here I've just laid out the criteria. So you need the diagnostic criteria for FES. You need 1 major criteria and 4 minor. But having said this, if you do think that there is any sort of FES complication that may be there, get on to transfusing them as quickly as possible. So that was our last case. Again, a really short one, just going through what sort of blood specifications to ask for and FES as a complication, and just to draw your attention there. I'm going to hand back to my lovely colleagues to answer any questions or comments or any things you want to discuss. So please pop in the chat box or pop your hand up.
Whilst we're waiting for some questions, as I said, because we're all sort of ED background, we're all loving this question because it's about trauma. I think the main thing to point out about paediatric trauma is that it is rare for everyone in the UK anyway as a whole, irrespective of their sickle cell background or not. So we're seeing roughly about 900 major trauma cases across the whole of the UK yearly. So in the grand scheme of things, there isn't a huge amount of paediatric trauma experience, even in the major trauma centres. So adult trauma is still far outweighs paediatric trauma. I think the main thing in this background is that we still concentrate on managing the major principles, as Shrina pointed out, the CABCD approach. Sickle cell, although making sure the blood products try to match as best they can, it still comes down to what's causing the life-threatening injuries and what could be done from a trauma point of view. Stabilisation, stopping the bleeding, getting blood in, and then transferring to the centre that will be able to maximise the injuries that have been occurred in this sort of situation, sort of battle surgery or specialist care. So you're still thinking of that in the background, and sickle cell just happened to be a past medical problem of this patient, but shouldn't be the overall riding issue here.
I think this case I really like because it brings together what we were trying to do was talk a bit from the emergency department point of view, recognising that on the call we've got haematology expertise, and just kind of as a general point about all of these cases, going back to Shrina's opening slides about the importance of this topic, there's kind of the bit from the vaso-occlusive crisis study, and really sadly a huge chunk of patients saying that they sometimes avoid care in the emergency department or delay treatment because their experience has been poor. And that this is the most common inherited disorder. It's more common than cystic fibrosis in the UK, but it doesn't get the same traction, I feel, in terms of education for clinicians. So I guess just my chance to just put a challenge back for all of us. We're trying as emergency department clinicians, how do we spread knowledge amongst our colleagues? So we're planning to do a session for the kind of national teaching programme for paediatric emergency medicine trainees. How do we all work together so that we get that haematology expertise and draw it in, so that emergency department staff can be better equipped to give these patients excellent quality of care, particularly in areas where there are sort of fewer of these patients. And I know the networking that's happened for inherited blood disorders has really helped with that, but it's something that I'm really conscious of and would love your thoughts on as well, if there's anyone else wants to chip in on ways we can try and push this forward for patients across the UK. And we've got a couple of extra comments coming in, and I think a hand raised as well.
I think Mark, your hand is raised again. Mark Leighton.
Yeah, thanks. Well, thanks. Very interesting cases as well. Just going back to the transfusion question again, this is something that is worth just mentioning, which is that there is a national database held by the Blood Transfusion Service, NHSBT, which includes information on the extended phenotype of the majority of patients with sickle cell disease. So that's blood transfusion laboratories will be aware of that, and that should minimise the need to give them blood that's not matched. And I'm sorry to harp on about this, but it can become a real problem if patients are alloimmunised, because unlike many patients who suffer major trauma, they might never need another blood transfusion. But this is a group of patients who might, over the course of their lifetime, need multiple blood transfusions. And if they are alloimmunised, that can become very, very difficult in terms of finding compatible blood for them.
Mark, it's Jeff Morgan speaking. Just to ask, is that directory, is that UK wide, or is that England, or is it different for NHS Wales and Scotland?
NHSBT, so it's probably, I'm not sure if the Scottish Blood Transfusion Service is linked, but it's certainly England wide. Yeah.
It would be interesting actually, with our trauma networks, we have the TAR network, and it would be interesting actually to look at the paediatric data collected for TARM on sickle cell patients. That's something which I'm not aware has been done, and as Chris alluded to, there's not many severe paediatric trauma cases across the UK. There is enough to keep us busy, but you know, it's a small number for each individual major trauma centre. But actually, all the data going to TARM would be quite useful to collect and to review at some point, I would think.
Yeah. I mean, another issue, I suppose, in that context might be tourniquet use as well, because that's problematic in cell disease. But obviously, you know, in a major trauma setting, you may have to consider that.
What I find interesting in this case, it does throw in a number of the potential risk factors for patients with sickle cell. You've got a fractured limb, an open fracture, you have the bleeding, you have the potential for exposure, the time delay in getting to somewhere remote. So from a trauma perspective, we have to think about what we call the triad of death in trauma, the hypothermia, the acidosis, the coagulopathy, on top of the background of the patient with sickle cell, who then presents with its own management challenges. So this certainly would be a very interesting case to manage in ED. And again, I'll reiterate, it's not something we'd be managing alone. We'd be seeking advice from our haematology colleagues, orthopaedic colleagues, and probably the paediatric intensive care colleagues as well. Is there any other comments, or anybody else want to comment on any other of the cases we've discussed today?
Lovely. If there's not anything else, I am aware of everyone's time. just want to wrap up the next couple of slides just to say, go over everything really briefly. So in terms of advice to give to parents and carers, educating caregivers to regularly palpate for splenomegaly, as we've said, advise them to recognise clinical signs such as pallor, to allow them to go to their closest hospital or to seek medical attention quickly, and to ensure that the patient has identification cards or bracelets or something on them that teachers and are aware when they go on school trips or when they're out of area. So just things to always, I know parents will know, but just to reiterate to them as well. So let's just go through the generic assessment and management of paediatric sickle cell patients in A&E. So triage, what you want to do, you want to look at their presented complaint, take a very brief history, look at their vital signs and flag up if they need urgent intervention, and review their transfusion card if they have one on them. At your assessment, when they come to us, look for saturation. Have they got a baseline? Have they dipped from there? What's their temperature? What's their hydration status? Make sure that we assess for neurology as well, and as we've said, assess for pain with the appropriate pain scoring. Investigation wise, you want to do a full blood count, reticulocyte count of blood film, alert your blood bank about their blood group cross match, use an LFTs and a CRP and blood culture if you think there's any sort of infection in the background. Blood gas, a capillary blood gas, really useful, really quick. And in terms of imaging, chest x-ray plus a CT if you think there's been any sort of neurological decline. And then with their acute management, just the key principles I want to highlight is oxygenation, target the saturations above 95 or within 3 of their baseline. Early pain management, review every 30 minutes to an hour. Make sure you give them oral or IV rehydration, that's really important. And keep a check on their fluid balance as well. Start IV antibiotics broad spectrum. You can look to your local guidelines for this, and liaise with a paediatric haematologist as soon or as early as you possibly can so that they can help guide your management. Just a small list of references. I've popped a little QR code here. If you scan this with your phones, that will give you direct access to the paper, the full paper that this presentation is based on. I'll leave it up on the screen at the end. And another thing, the next slide just shows if you have any questions regarding haematology, Indu Thakur is our our lovely consultant to go to, unfortunately couldn't be here. But then if you've got any A&E related questions or any questions related to this presentation, Jeff Morgan, that's his email, and he's on the call with us, who's answered a few of our questions today and discussions, and he'd be your person to go to for any questions. Ralph will be circulating a feedback questionnaire. I'd be really grateful if you could fill this in and send it back to us. It'd really help with any further presenting that we do as a team. Really grateful for all of you being here on a Friday evening. Thank you so much. If there's any other questions or comments, love to discuss. Thank you. Thank you for all your lovely comments on the side.
Thank you, Shrina. That was really good. And thanks for taking the time to present.
Yeah, I might email you separately to find out how you do this scan code thing. That's very snazzy.
Absolutely, anytime.
A recording of the session will also be emailed out along with Shrina's questionnaire afterwards. Thanks, everyone. I hope you have a great weekend.
Thank you, well done, Shrina.
Thank you, Ralph.
Thank you, everyone. Thank you, Ralph.
Thank you.